Now let's switch gears and talk about autosomal dominant disorders, and these are going to involve regulatory proteins, structural proteins, receptors. One of the most common that one comes across clinically as an example of an autosomal dominant disorder is familial hypercholesterolemia. Incidence is 1 in 500, perfect for the USMLE. Since you have 350 questions, the incidence will be increased when you take the exam. The defect involves the cholesterol that's being, as you remember from physiology and biochemistry, is the LDL receptor gene on chromosome 19, which is defective. And there are 5 major classes of mutations that can affect the normal synthesis and degradation and recycling of the LDL receptor gene. It can be involved, there's no synthesis of the LDL receptor. Obviously, that would accumulate in the blood because LDL would accumulate, leading to accelerated atherosclerosis. Class 2, you have to transport the receptor out of the endoplasmic reticulum because that's where you're going to synthesize it and then transport it through the Golgi apparatus to be expressed on the surface of the cells. And then there's class 3 where you have a defect of the LDL receptor binding to LDL, therefore leading to hypercholesterolemia, and that by far is one of the most common that one sees. And then, as you recall, that the LDL receptor has to be aggregated as a group. You get these pits that now gets internalized back into the cell, and if that's defective, that could lead to the inability to bring LDL into the cell to be metabolized, like in the hepatocyte and other cells, and then the recycling of LDL receptor back up to the surface of the cell. But by far the most common problem is LDL receptor binding. It's defective. And what is the problem of having so much cholesterol? As you would anticipate, it's going to cause damage over a period of months and years to the lining of vessels, especially on the arterial system or side. And basically this increased cholesterol and the lack of inhibition of HMG CoA reductase, that what's going to happen is that it's going to cause damage to the arterial side, high pressure, and accelerate atherosclerosis. And you're going to have macrophages accumulating the LDL within them, what we call foamy macrophages. Anytime you hear that as a description in a biopsy or in choices on an exam or in a biopsy report or autopsy report, one has to always think about, when you think of foamy cells, you think of lipid-laden macrophages, because they like to eat just about anything. Remember, one of the functions of a macrophage is phagocytosis. So when we talk about familial hypercholesterolemia, the presentation is obviously an elevated cholesterol level in terms of milligrams per deciliter in the serum. Heterozygotes that can have elevation of 2 to 3 times normal, and homozygotes of this condition, obviously the severity is going to increase the levels 5 to 6 times of normal. And then the higher the level, the more likely you accelerate atherosclerosis and present early on with the stigmata or sequelae of atherosclerosis. And these include what? Skin xanthomas. They're going to be yellow collections of lipid-laden or foamy macrophages in the dermis of the skin, especially you can be visible around thin areas of skin like around your eyelids, for example. They can be, you can see it around the eyes as these xanthomas, xantholasma. And then what's going to happen is, typically when you think of atherosclerosis leading to cerebrovascular accidents like an infarct or coronary artery disease leading to MI, myocardial infarction, you tend to see this in the 40s and 60s, 50s and 60s, but you'll have a familial history. You have a father, a mother dying earlier, a brother, a sister, and usually earlier on, you may have a brother that dies of a heart attack at 35 or has a heart attack at 35, depending upon how much heart muscle has died because of it. Or MIs can be as early as in the late teens as well as the 20s. Another important autosomal dominant disorder that involves structural protein is Marfan syndrome. And we had mentioned this earlier when we talked about a genetic defect involving the fibrillin gene on the long arm of chromosome 15. And fibrillin is very important because it's an accessory extracellular protein that helps the alignment and structural integrity of collagen and elastic fibers. And fibrillin is a glycoprotein, And again, it's the alignment of connective tissue proteins like elastic fibers. And the distribution of the disease, when you think of this, is a skeletal system, since there's a lot of collagen type 1 found in bone. So you can have abnormalities. You have these tall, thin build with long extremities, what are called marfanoid stature or appearance. The connective tissue, we think of the joint capsules, their tendons and ligaments. That one thinks about, you get a hyperextensibility around the joints. What's going to happen, you have abnormality in terms of chest wall development. You may have an inwardly depressed sternum or pectus xvid. And you can also have the chest pointing out, or pigeon breast, or pectus carinatum. And then it can affect other sites like the eyes, where you get ectopia lentis, where you basically, the ciliary process that attaches to the lens has connective tissue as well as fibrillin protein, and you get what displacement of the lens called subluxation. But the most important organ system where the elastic fibers become critical is the cardiovascular, where the lack or defective fibrillin protein will lead to structural weakness of the cardiovascular system. And what used to be called, you probably may have learned this, as cystic medial necrosis. It's not really necrosis, but it's cystic medial degeneration of the media of the elastic arteries. And what happens is a function of time, because of the constant barrel process of the blood pressure during systole and diastole, you're going to lose elastic recoil and degeneration of the wall of the media that makes up the bulk of the aorta. What you'll develop is either a dissecting hematoma or aortic aneurysm as a reflection of structural weakness. Now you may ask, where's the most common site? Well, this is where physiology becomes important in ascertaining what's going on, because when you look at this, you're really thinking about, as blood pressure goes down from the ascending arch of the aorta, thoracic aorta, and abdominal aorta, remember that the blood pressure is decreasing in terms of its amplitude, and so therefore, if you have a structural weakness, where are you going to see it? At the greatest amplitude. In this case, it usually will start at the ascending aorta. What venereal disease you learned about, because it can cause aortitis and also lead to a aneurysm of the ascending aorta, is syphilis. So you get aortic dissection, and it can rupture through the wall and then lead obviously to a massive hemorrhage and lead to death. And then, because it's affecting the ascending aorta, what can happen with the dilatation, it can affect the root of the aorta that's now connected to the aortic valve and cause basically the aortic valve to dilate, and leading to severe aortic valvular insufficiency, or what we also call regurgitation. And then what can also lead, as you have more regurgitation from the aortic valve back into the left ventricle, it can also increase the likelihood of mitral valve prolapse as well as by itself. Another area or conditions that can involve structural protein, the most common structural protein is collagen, is the conditions called Ehlers-Danlos syndrome. And basically, it can affect the collagen molecule itself or the enzymes that go through the process of synthesis as well as cross-linking. So what are the clinical features? Obviously, collagen is found in skin, joints, and ligaments, and can lead to structural weakness and lead to hyperextensibility of joints, hyperextensibility of skin, wound dehiscence. It would be a problem because you need that collagen in order to provide structural integrity to the wound, so it can easily tear apart. And then there are various variants, or roughly 10. Do you have to memorize this for the USMLE? The answer is no. But it depends upon the various modes of inheritance. One can see, for example, if it involves collagen itself, it would be autosomal dominant. If it's autosomal recessive, it would be the enzymes that are important in the synthesis of collagen itself. And so these are just some examples that are listed in your syllabus as well on these slides. And basically, it can affect collagen type 3. Remember, we have over 29, but the first 4 we talked about earlier are the ones you need to think about. It can affect the lysosomal hydroxylase enzyme that's important for hydroxylation of lysosine residues in collagen. And then the other thing is there's an autosomal, or not autosomal, but X-linked recessive defect. It involves copper, remember, is a cofactor for cross-linking, and it's found on the X chromosome. Other things we have to think about: what are the complications of having structural weakness to various organs that are dependent upon the various types of collagens found through the body? Obviously, poor wound healing, either wound dehiscence or delay in wound healing. Obviously, there be extensibility of the joints should lead to dislocations very easily on minor injury or use. The other thing you have to worry about, collagen is used in the diaphragm, so you could get diaphragmatic herniation, especially on the left side, where you could have the spleen and the stomach and small intestine as well as the large intestine going up into the left pleural cavity. You can get, obviously, the collagen important for the retina to be attached to the eye, and so therefore you get retinal detachment. It can also affect bone development, getting curvature of the spine problems like kyphoscoliosis. And then the other thing you have to remember, high pressure systems like the cardiovascular system, where you could get aortic dissections or rupture. And then where in the GI tract you have a high pressure system is the colon, because as you absorb electrolytes and water, the fecal material will become more solid, and therefore it takes more pressure to expel it on defecation. So therefore you could get rupture of the sigmoid colon as a consequence to this. Another autosomal dominant disease is called a condition of proliferation of neurofibroblasts, especially along nerve trunks, is called neurofibromatosis. And the classic type 1 is the most common. Another name for it is von Recklinghausen's disease, and it accounts for about 90% of all cases of neurofibromatosis. Frequency is 1 in 3,000. The genetics involves the tumor suppressor gene NF1, and it's on chromosome 17, the long arm of chromosome 17. And what its important role in life is that this neurofibromin, which is the gene product of the on chromosome 17 and NF1, and what is its role in life? As you remember that when you transduce a signal from a receptor on the surface of a cell, you have GTP binding proteins that could be inhibitory or stimulatory to the transduction of that signal. So what this particular gene product of neurofibromin is that it's going to inhibit what is called P21, or the RAS, or the GTP binding protein, and therefore modulate the transduction of signal into the cell. So obviously if this has now been removed, this inhibitory effect on GTP binding protein, then you're going to lose control of the effect of transduction of a signal through the cell. So when you talk about neurofibromatosis type 1, what do we see clinically and pathologically? You will see a variety of proliferations of fibroblasts within the nerve trunks, giving you this beaded appearance to the nerves itself. We call these neurofibromas. They're basically benign tumors of fibroblasts, and they tend to be numerous, and obviously if they're superficial nerves, they can cause disfiguration, especially when you have nerves in the head and neck, and they can also be seen obviously in the distal part of the body as well. And they can be what they call plexiform. They're in terms of their histologic appearance of the fibromas under the microscope, where you basically have this interweaving, basket weaving of these proliferating fibroblasts. And malignant transformation to a neurofibrosarcoma is extremely rare, and you won't even see it on USMLE either. Another important clinical correlate that one can see physical changes is what the famous cafe au lait spots, which are pigmented macules of pigmentation. In order to make the diagnosis, you have to have 6 or more of these cafe au lait spots. You can have 1, and that could be a normal variant as a birthmark, for example. And again, macules, they're light colored brown, and they're usually located the nerve trunks that are involved with the neurofibromatosis. And again, you have to have 6 or more when a patient is typically diagnosed with neurofibromatosis. You can also get excessive production of tissue in the iris. We call these hamartomas. Remember, hamartomas are proliferation of normal cells. They're not going to be what we consider neoplastic, and these are called clinically less nodules. Then the important thing you have to remember about this condition, it increases the propensity of developing other tumors. And the things you can increase the risk is meningiomas. Remember, the meningiomas arise from arachnoid cells from the dura. And then a rare tumor, except on the USMLE, is pheochromocytoma. And remember, there are a number of autosomal dominant diseases that are associated with pheochromocytoma, like multiple endocrine neoplasia type 2 and 3, for example, or as well as neurofibromatosis type 1 associated with pheochromocytoma. So why do they call them pheochromocytomas? And this is important. Even though they're rare, we know they arise from the medulla. Chromo means what? Color. What is pheo? Well, pheo means dusky or dark colored. Because if you think of the cortex of the adrenal gland, we talked about early on in chapter 2 about various colors, that remember that the precursor molecule in the cortex for all the hormones you learned about involving the cortex is cholesterol. So when you have cholesterol lipid, then those xanthophils will accumulate. But remember, what is the production, what is being produced in the medulla adrenal gland are catecholamines, non-lipid. So relative to the cortex, the medulla will be darker in color. And so hence the name pheochromocytoma, just means dark colored or dusky colored tumor. Remember to use the dictionary, studying for the USMLE. Neurofibromatosis type 2, the old name for it clinically was bilateral acoustic neuromas or neurofibromatosis, or what's called the central form of NF or neurofibromatosis. It only counts for like 10% of cases of neurofibromatosis, and you can see by the frequency of 1 in 45,000, it's not that common. And in terms of the genetics, it involves the tumor suppressor gene, but this one, NF2, is located on the long arm of chromosome 22, and basically its gene product is called Merlin, and it's a critical regulator of contact-dependent inhibition of proliferation. Normal cells, when they are dividing and they touch one another, they will stop dividing. This is what's called contact-dependent inhibition of proliferation. Obviously, there are genes that control this. One of these is Merlin, or NF2. So now if this is defective, then when cells that are defective in this gene product of NF2, what's going to happen is these cells will not stop growing when they touch one another, so they've lost the ability to inhibit proliferation, and is one more the further step to go on to neoplasia, which is described as a multi-step process, and this is one of the steps that would be necessary. Again, you're going to see pathologically as well as clinically the bilateral acoustic neuromas. They can be schwannomas or neurofibromas. You often get capital A spots and less nodules you will not see in the iris of the eyes. And they also increase the risk for tumors like meningioma and ependymomas. So they're going to be primarily tumors of the CNS that are benign. A rare condition except on the USMLE, and you'll see why in a moment, why it's going to be asked, is von Hippel-Lindau disease. And this genetics involves the tumor suppressor gene VHL for von Hippel-Lindau disease. And this is a tumor suppressor gene that's located on the short arm of chromosome 3, and its normal gene product is to tag proteins with ubiquitin for degradation. Remember that in all cells that there's a constant synthetic component to making molecules as well as a degradation. And one of the ways that cells help to signal that this protein or molecule is ready to be degraded is to label it. And one of the labeling molecules is ubiquitin. So you can imagine that if you had a problem of important proteins that, say, regulate growth or suppression of growth, that if you don't have it be ability to label it in terms of degradation, then you could lead to a proliferative state and lead to neoplasia. What is the clinical presentation? It's associated with von Hippel-Lindau disease, and we'll give you a little story to remember why they call it von Hippel-Lindau. Von Hippel basically was a physician who described and studied this tumor called a retinal hemangioblastoma. Not as important to memorize that it's hemangioblastoma, but it's a vascular tumor. That's the critical part. Then Lindau came along, and he was studying the same histologic type of vascular tumor, but other parts of the CNS, and they realized they had the same disease. Hence the name von Hippel-Lindau disease. So it's a vascular tumors within the CNS. You can also get vascular tumors or cystic changes like in the liver, pancreas, and kidneys, but the real kicker is the last part of this slide, is that what is the most common malignant tumor of the kidney in adults is renal cell carcinoma. And so in these patients who have von Hippel-Lindau disease, 50% of these patients will develop multicentric, which means more than one renal cell carcinoma in each kidney at the same time. So obviously, this is not going to have a very good prognosis, so both kidneys have to be removed to, especially when you see renal cell carcinomas, because of the high likelihood, obviously, of metastatic disease and a short lifespan because of it.